Parikshit.
Thank you, Lahane sir. I would request all the persons in the last row, there are seats in the front. So in case somebody else wants to come, they can come and sit. You can please, you're welcome to sit in the front. Well, thanks to sir and ma'am, we run this course for the last almost 10 years and always there are enthusiastic takers. It's heartening to see manual SICS halls are always full and there is so much that manual SICS can do. Today I have been given a brief to speak about the various techniques of small incision cataract surgery. I'll be just running you through the 10 techniques that are the most common ones that are possible. But before I do that, this is just a small video of the technique that we most commonly do, that is visco expression. This is a technique that was first started, popularized in Arvind Eye Hospital. You make the tunnel, you put in lot of visco and you just press on the floor of the tunnel and the nucleus just glides out. So it looks very simple and well, it is in many ways simple. But as everybody who has done both phaco and SICS knows that in many ways SICS needs more skill to do than phacoemulsification. But there are various places where manual SICS is as good or perhaps even superior to phacoemulsification. Hard cataracts, brown cataracts, many kinds of subluxated lenses, places where corneas are not very good, that is very old patients or patients with Fuchs endothelial dystrophy, the SICS is much, much better. So in the SICS, there are actually two places only where we have to have more skill. Even in phaco or in any cataract surgery, we need a good tunnel, we need a good CCC. That is now a norm, a prerequisite that all of us have to do. Here, prolapsing the nucleus into the anterior chamber is the key step in almost all SICS technique, and that is why having a well-dilated pupil is very, very important. So using NSAID eye drops before surgery, seeing to it that a proper dilating thing is put before surgery is very important. I mean, if we have not promised the patient, even peribulbar blocks work well, subtenon blocks work well. People do SICS under topical anesthesia, parabulbar anesthesia, but for long-term safety and especially where high volume surgery is done, peribulbar block or subtenon anesthesia is very important. Also, small pupils make nucleus delivery difficult and increase the chances of manipulation of iris and cause iritis. So we should avoid that. We should take steps preemptively to see that the pupils are not small. These are the 9 most common types of SICS that are done. Of course, everybody has his or her own variant, but the irrigating vectis, the blue menthal, phaco fracture, phaco sandwich, phaco trisection, the fish hook technique, the snare, the intratunnel fracture, the smart SICS, nowadays the 3 millimeter SICS, and the list keeps on growing. This is the one, the irrigating vectis or visco expression, in which we have a slightly larger incision and the vectis keeps on giving out water, and when you press on the lip, there is more pressure inside, less pressure outside, and the nucleus glides out. This is the video we just saw. It's a fast procedure. There has to be a well-formed anterior chamber throughout the procedure, and the brunt of the nucleus is borne by the walls of the tunnel, and this is safe for the corneal endothelium. In the blue menthol techniques, the lovely videos that Professor Agini ma'am had shown, there it is the AC maintainer that is maintaining the anterior chamber, which is keeping the nucleus away from the endothelium. Here it is the irrigating fluid and also the viscoelastic. So in many ways, it is like getting the paste out of the toothpaste like we do every morning. We open up the nozzle and we press. Now, if we press gently, the toothpaste or even eye ointment will come out gently. If it is done in a haste, then too much of ointment can come. So if we try to do this too fast, the nucleus can come out too fast. There can be a decompression inside and it can lead to a PC rent as the vitreous comes up. So the internal hydrostatic pressure has to be maintained. The nucleus is stretching on the walls of the tunnel And here, of course, we are giving pressure on the posterior lip, sorry. And by giving pressure on the lip, we are opening the mouth. So the more controlled this is done, the safer this is for the patient and for us in the long run. These are now only of historical significance. This is phaco sandwich. Well, we are all very proud that India is the home of manual small incision surgery, or rather the Indian subcontinent, Nepal, Bangladesh, Pakistan. But some of these techniques were first tried in the United States in the 1980s, before phaco became popular. And here the nucleus is squeezed between the lens loop and the iris spatula. Now, because it's a large nucleus and we are putting in two instruments, we need a larger tunnel. But some of the nucleus that we see in the Indian setting are very, very hard nuclei. So to get that into the anterior chamber and to put two instruments, one below and one above, sometimes can be difficult. The same problem is there with the phaco fracture technique, which was introduced by Dr. Peter Kansas again in late 1980s, where there was a bisector or a trisector, which would divide the nucleus into two pieces. So the bisector would chop it into two. A trisector will make it into three. The trisector was easier because the resultant pieces are now three pieces, and we can remove them by McPherson one by one. But again, if it is a very big nucleus, the trisector on top, the platform below can make it very difficult. Compared to that, in the Blumenthal technique or the visco-expulsion technique, we just put pressure on the lip. We do not put any instruments inside. So this is the Blumenthal technique, the lovely videos that ma'am showed. There is the sheets glide and the AC maintainer, which has less than 1 millimeter diameter. This keeps the AC formed all the time, and you don't need a lot of viscoelastic. So all the problems with remaining visco, so secondary glaucoma, perhaps later uveitis, all of them are avoided in the Blumenthal technique. And because the AC is formed all the time, chances of iritis, chances of endothelial damage are also very less. In fact, it is this technique that made SICS more common. Sure, okay, we'll do this later. Again, all of them can be used for black cataracts, for brown cataracts, for hard brown cataracts. And again, we all emphasize too much on the small incision cataract surgery. But then some of the nuclei that we see are really very big. In phacoemulsification, the nucleus is broken down into literally micro particles and just aspirated. Here we are removing the nucleus in toto. So in case you see a very black cataract, it makes a sense to have a slightly bigger tunnel, the inner lip much bigger than the outer lip, to have very good scleral pockets, because once the nucleus comes out, it will need space for it to come out. And also for the nucleus to get into the anterior chamber, the rhexis also will have to be much larger. A lot of us surgeons today are used to doing phacoemulsification, so we tend to make the rhexis smaller so as to have good lens centration. But in cataracts like this, perhaps slightly bigger rhexis are needed. And the nucleus delivery and all the various ways we saw is the most traumatic step for the patient and the surgeon, especially when we are learning SICS or when we are converting from phaco to SICS for whatever reason. So the tunnel has to be adequate and proper. See that the nucleus is bathed in visco, and nowadays we have excellent viscoelastics. And we have done randomized control trials trying to compare HPMC, that's hydroxypropyl methyl cellulose, which costs 50 or 60 rupees, with sodium hyaluronate, which costs 400, 800 rupees. And well, there is hardly any difference. But whatever visco we have, we should use it in plenty. This is not the time to be miserly. And the delivery should be gradual and controlled and not sudden decompression, as it can lead to a PC rent. And finally, in all the techniques, one thing always to be looked at is the corneal endothelium. These cells are not replaceable, so we minimize endothelial touch or endothelial injury either by the instruments, by nucleus, or by IOLs. make the maneuvers away from the cornea. And again, as surgeons, we focus too much on astigmatism. We think astigmatism is something that is very wrong, you know. Uh, that's why we do phaco and smaller incisions and toric IOLs. But in SICS, there is a trade-off between lesser astigmatism, that is smaller incision size, and corneal clarity, endothelial cell loss. We may make a very small tunnel and we may get the nucleus out, and we are very happy that the astigmatism is less. But 2 years, 3 years down the line, if we do the specular microscopy of these patients, their endothelial cell counts have fallen down. So it's not worth it. In fact, again, meta-analysis have shown that small amount of astigmatism in SICS gives near vision, because it's like the Stroom's conoid. The smart SICS techniques works on that, because the horizontal and the vertical corneal curvatures are slightly different. So that increases the depth of focus. So the EDOF lenses that we put, and we pay a lot of money to put in those lenses, something like that automatically happens in SICS. So when you, I'm sure all of you must have seen our phaco patients. In phaco patients, we are happy patient reads 6/6. Patient is not that happy because he says, I could read my mobile, I could read my newspaper without specs earlier, and now I cannot see anything for near. But if you will see your SICS patients, they may not read 6/6, they may read 6/9 or 6/12, but they are able to read or see their mobile. And nowadays, everybody has the mobile because of this effect, because of the small residual astigmatism that is there. And one last one is, of course, in SICS, if the tunnel is large or not that good, we many a times get a shallow anterior chamber, and that can be seen on the first dressing. So many people think that the suture is bad. Well, yeah, it's not the most ideal thing to do in a cataract surgery, but then wound gape or iris prolapse increase chances of endophthalmitis, astigmatism. So whenever needed, we should suture it. And finally, SICS gives best functional vision, unaided 6/12 for distance, unaided N8 or N10 for near, and it gives the best intermediate vision, which is what nowadays people want to do by putting in very expensive lenses. So it's a great surgery, and I'm sure